And what we need is the drug users to be involved because they know what goes on really in a drug user's life. And a lot of it's criminalized and a lot of it's shame, very much a shame-based activity. So when you have something like HIV, it's a very technical thing. People know how the bloodborne pathogen is passed on. They know how to prevent it. And then we try to do these prevention measures like with increased needles. And is needle exchange better, or should we be giving people unlimited numbers of syringes? Should we be giving drug users stipends to take away needles and say who they're giving them to and try to get them to keep track and give them small amounts of money to do that? And call it research. Actually have drug users involved in publishing papers about their experiences of doing the outreach to prevent the HIV. The things we know not to do, and I would say comes from Vancouver's experience. At one point, Vancouver was giving out 3 point something million needles, and Stephanie Strafty recorded this huge outbreak of HIV that went on during this very high number of needles that were being given out. And it isn't about how many needles you give out, it's about how you give them out and when are they available at night. So we were also lucky enough to have a research project going on in Vancouver from the beginning of this outbreak. And so what the drug user group did was we really became activists. There was a kind of a naivety at first, we'll tell people, people are dying and something needs to be done. But as a year and then 2 years and then 3 years go by and nothing happens, you start to get a little amped. So pretty soon we were marching in the streets with placards thinking, maybe people aren't aware. So each strategy was, we tried to take a sort of a scientific approach in the sense that this is a strategy we're going to do a bunch of demonstrations. Another strategy will be we're going to say that when, try and take issues from the floor of the drug user meeting, write them up on the wall as the popular education model will tell you to do, and then decide what action you're going to take and then have everyone do it. So we would engage with the police around some of their practices. We would engage with the hospitals around their practices. And over the 13 years now that VANDU's been in existence, we've had many, many campaigns. The initiative to do the illegal injection site was really a way to bring public attention to it. We were lucky enough that there were arguments going on. The mayor said no to the police. They couldn't come and arrest us when we were doing it. And I've never been arrested, as it turns out. But we were sort of prepared. We had lawyers in case we got arrested. We had a sense of what would our court case be about. If the government won't act to save lives and initiate public health, then we as citizens feel we must. And we had some courageous we held a press conference much like this, and we had PhDs and MDs who would say, as a mother and a physician, this is very important that they have this guerrilla unsanctioned injection site or whatever. And she's talking about then the data and her expertise. And she wasn't fired from her job. So you start to creep out and feel how much you can get away with. And the passion that's always in the mind was mostly initiated by Bud Osborne, who kept saying to us, let us always be guided by the poorest, most disadvantaged drug user that you'll see who's like on the street, who's having the most trouble. In your mind, you're thinking, will this campaign help them? And if it doesn't, he said, drop it. If it's going to be a fight between you and another agency about who gets the funding, you're going to have to let go of it and go back to the guy that you're remembering. Who is it that you want to be advancing the cause of? Our philosophy was that if the most marginalized drug users could advance and have their lives saved and have access to, if it was needles, injection sites, heroin prescription, methadone, we fought all these fights. HIV treatment also, and Hep C treatment, these are other fights. I mean, it's lots of fights. But the most important thing was that if the most poor marginalized users could get them, obviously the more privileged drug users could get them too. So we tried to be guided by that and tried to have those people in the group run the group rigorously, democratically, and then you allow this, whatever the next problem is, the drug user group can kind of be sent out, to be the scouts, to see how to feel the waters. There's a lot of concern that people will lose their jobs. Bureaucrats may not want to speak out. Some bureaucrats will speak out. But I think once people have, like this film does so well, has the experience of listening to those people, it really does move you to tears. It clicks in a place where you start to say to yourself, what ethically and morally can I not do now that I know? Which was my problem personally. Quite often I wanted to quit, and then someone would come up and say, VANDU is the most meaningful thing that ever happened to me in my life. I think, oh, don't tell me this, I'm quitting tomorrow. You know what I mean? So I think I'm not sure what else I can add. The campaigns, some of the stuff we need to know about and understand, and VANDU's latest campaigns are focused on this, and I hear it's coming here because it's a federal thing, but it's also each province is paying their own, is this mass incarceration idea. And as tempting as it might be to think that if people who are really, you see them out there, they're really messed up, they're the ones that are getting HIV, they're very, very addicted. If they go to jail, they're going to be clean, they're going to be fed. This is not a good way to do healthcare, prisons. All the data shows that people who cycle in and out of prisons have the very highest rates of HIV and hepatitis, and that we need to say, and they're also very costly. It's $80,000 a year per person. I think if that's it's between 60 and 80. It's very, very costly. Clearly, you could buy someone a condo for that easily, but we won't go into that. But the issues of the intersections of lack of access to clean drugs in a legal way, if people can't get drugs, and then the use of those drugs and homelessness, incarceration. These are the things that create the perfect storm of high disease rates, and that's how we just sorted them. And we found that by using the expertise of the drug users, they were the ones who knew what it was like to be arrested. They were the ones who knew how you treated when you went to emerge with an infection or an overdose, and they were always the voice that we went from. I'll also say it's a lot of trouble to work with drug users who are active drug users, and there's a lot of problems doing that, but it's highly worth it. And I think that the drug user group says we take a lot of credit for the changes that have occurred in Vancouver because of the courage. People who have a job may be afraid to lose their job. An agency that's funded may be afraid their agency is going to be disfunded. We found the drug users personally didn't have a lot to lose in that their lives were at stake, so they had a lot of courage, and the drug user group always tried to keep that foremost. I'm not sure if there's other comments I wanted to make about, is there questions now, or is there something I missed?
Just maybe specifics about the drug strategy.
Well, the drug strategy that I've seen here was, I noticed there was an announcement that they were going to be restricting the number of needles that they were giving out, which hasn't worked anywhere that I know of, and I've certainly read all the research on this. What I would say is making sure, like doing a survey of the drug users and finding out when they're sharing and when they're not sharing, and finding out at what times and what places they're not getting out to and why they're not getting out. There was a sort of abhorrence for the idea that drug dealers would end up with syringes. Like, get over it. There's been campaigns, historically there was a campaign in Sydney, Australia, where people really just sort of held their nose, and these guys that ran these, I guess they were pimps, they ran little kiosks where women were selling sex, but often injection drugs took place in there. They made sure that those guys had cupboards full of needles and ensured that the person that you're trying to get the harm reduction to gets it, no matter how you may have qualms about the people that you're dealing with in that situation. So it means constantly being extremely practical, even when it feels uncomfortable. The idea that you want people to stop using and they're not stopping using is also uncomfortable for many, many people who don't use drugs. So the idea that more needles will lead to more drug use is simply not true. And one of the ways you can sort of test that in your mind is when you see people who have recovered from being alcoholic, they don't go and picket liquor stores and bars and try to get them shut down, because they don't blame them for their addiction. Addiction comes from another kind of problem that people have, and we need to keep that attitude in mind when we deal with people who use drugs. Because they've been criminalized, I think that it takes a lot of us a long time to de-brainwash ourselves. Every Rockford Files and every Hollywood has just plugged away at ensuring that all of us picture a drug user as someone that a cop kind of slams against a wall and they'll sell out their mother or their child or anyone. They have absolutely no moral ethics. And that's been really fed to us about how drug users are, and it's completely unfair. So it's important that as we work with drug users and work on a campaign of saying how is it that people who have this disease and are spreading it just amongst themselves, but it'll spread into the general population as well. We need to have a sense of dignity and give them the voice and start to move forward with them rather than condemning them to creating even more problems. The last thing I wanted to say was there's an epidemic amongst Aboriginal people, and I've been very inspired by the work of Michelle Alexander, who wrote a book called The New Jim Crow. And what she does that's so important in looking at the epidemic of drug use amongst black people, and also the mass incarceration of people who have been put in jail for drug use and, well, just for being black, one might conclude. And we have very similar situations, certainly on the prairies. There's very high rates of incarceration amongst Aboriginal people. And we know that the children of prisoners and the children of drug addicts have much higher risk factors for becoming, being jailed later in their lives or becoming drug addicts. And I think it's important as we work with Aboriginal youth that we speak to them in such a way that they can grieve their losses, be able to understand what's happened within their families, but take pride that they can start building and looking at other social movements where an oppressed group has been able to regain rights and regain health within their community, so that we don't inadvertently cause hopelessness amongst them, but also that they're told the truth and they start to stand up and say, you know, we're not going to jail and we're not going to be hurt in this way, and that they can admit that they come from this place. I'm not sure if there's more.
What'll happen now is Anne's going to go do the media conference. We're going to watch the film for 10, and then Anne will be back, and then we'll finish the film after you've had a chance to talk and interact with Anne.
I moved to Vancouver in 1993, and it was right when all these overdoses were going on, like the first big batch of overdoses, and we still considered to have a low HIV rate. And I have a child with a disability. He's 30 now, and he was probably 12 then. And I had 2 other little kids, so I was a stay-at-home welfare mother living in a housing co-op 2 blocks from Main and Hastings, and I had just moved there, and a woman died in the alley, and we went and revived her. And I just thought, you know, maybe someone doesn't realize there's a problem, like, duh. And then it's the big hook. You keep thinking there's one more thing you can do and it'll really make a difference. So many, many years went by. But that's what I thought. I thought I know how to do community organizing. And I met some other people and stumbled on a 4-day Nicaraguan course in popular education, and just started. We had no money. We did it as volunteers. We were slapping up posters and holding these meetings. And it's I tell you, the only other thing that really, really can be when you struggle with it for a long time, and people like the police will never meet with us, and they won't, you know, you end up with this sort of wall there. When you've got the illegal injection site and the police aren't allowed to arrest you, it's just like, oh, I lived my whole life for this moment. All right. You know what I mean? And it's not much of a victory. Lots of people died, but you know, just in terms of being able to, it's just so shocking. It's really shocking to realize that some people in our society are disposable, and it's so. I might have been the only Canadian that took it on that as a little child. I was just shocked by this behavior. I was very naive, and it kind of kept me going. So that, and then the model with people with disabilities have created this whole movement. And John McKnight was the guy who I met that made the biggest difference to me. So, you know, you got some guy and he's completely disabled, except he remembers everybody's name or something. And then they would find this place for him in the community, and he'd sit in this town. He'd always sit in the cafe, and people came in and said, "So what's up, John?" And he'd tell you everything. And he had a little radio going on, so he was listening to all the police calls and the fire. He'd say, "There's a fire over at such a..." And this was the guy's role in the community. And as a mother of a child with a disability, you know, you're just like thinking, this is bad news. The kid's going to live in an institution. They're never going to be in the community. So when I talked to the drug users at first, there was nothing for them. They couldn't eat in the free food places. They couldn't sleep in the shelters. They weren't allowed in the community center. They were just kind of all standing in the rain in Vancouver, shooting dope and dying, and just awful. And when I first started working with them, we'd hold these meetings. We're giving $3. The room would be fuller than this. And we would be going, well, I guess this methodology is working. And then we just get them talking. And I'd say to them, you think you need services, but I advise you to go look at the mental health drop-ins. If you want someone to get $17 or $18 an hour to play cards with you because you're considered nuts, and a lot of the service doesn't make sense to people necessarily. And a lot of the first advocacy that groups do, like mental patients or women or Aboriginals or I don't know, however people get labeled in some way, the beginning part of it is really healthy, but then it can become sort of professionalized and everyone's kind of a client. And I mean, I don't think people should be paid, well, with me, I'd be mad if someone's getting paid wages to play cards with me and I got to live on welfare. I just think, you know, couldn't we redo the budget? So that's what we were doing all the time, was sort of warning them and saying, you better get involved in this budget. So that's the methodology I use. So as someone said to me earlier, like I said, the VANDU board meets every week. Like, this is shocking. If you've ever been on a board, they don't meet every week. But ours meets every week. And initially I used to laugh hysterically and say, it's a programming. That's how we do our anger management and our whatever, because we had no funds to do any of that. And yet they're really not clients. But you see all this skill develop. The story of VANDU that was so interesting is after 1 year, they came to take our funding away. And I used to torture these guys. Now, come on, look at the financials. And, you know, I don't know who's all looked at a financial that's got, say, $50,000 in it or something. And there's all these little lines and these columns and there's numbers all over a page. And there's like, they were mad at me. And then when the health authority came in and they tried to bamboozle them, and they gave them all a sheet and they said, this is how we're going to do it. And they looked at it and they could see the bullshit right there. They knew that their funding had actually been removed from them. And whatever, you know, they said, oh, we'll cater the food. But the drug users all wanted to make sandwiches because they could get a $10 stipend for making the sandwiches, and we'd all go shopping together. And, you know, it's just, it creates this community. It has all this trouble in a way, you know, this, you know, you got to wash your hands and you got to, you know, I mean, like just the trouble of troubled people, of broken people. I mean, we're all kind of like that. But, you know, there's this kind of confusion and chaos, and out of that, you know, the meeting's done. We got the 100 sandwiches, everyone, you know what I mean? There was a lot of involvement. That's how we viewed the thing. It wasn't about me hiring some staff to deal with them because they were our clients. And this is what is so shocking about VANDU, and this is what works so well with any group of people, that you can't make them less depressed by telling them they're depressed. It just doesn't make them less depressed. So anyway, I don't know, I went too long for that. Is there other questions? Yes?
I remember that you mentioned that this is Saskatchewan trying to restrict needles and stuff. What would you say about that?
I don't remember when the newspaper article came out, but I saw it because Garson put it on Facebook. And there was the problem, and this is kind of dumb, it's sort of technical, but again, if you designed this with drug users, you know right away. When drug users go into a needle exchange, guess what they've got in their pocket? Drugs. And guess what they want to do? Do them. And guess what they want the guy at the needle exchange to do? Hurry up! So there's a kind of amped up energy when you're trying to get the needles, to get the dope, to do the dope. And of course they have nowhere to do it. So they're going to be going from there, and the problems they're solving is how am I going to get to the needle exchange without getting arrested, get the needles, and then go find somewhere to shoot the dope. And, you know, is my girlfriend going to find out and she'll want half and I don't have any for her, and besides that, last week she shot with someone else, and you know what I mean, this incredibly complex bunch of stuff going on. What's worked like a charm, what's so incredible about the injection site is it wasn't set up to get people into treatment, but it is getting people into treatment. It was set up to prevent the spread of HIV, prevent overdoses, and prevent public drug use. But what they find in an injection site, unlike a needle exchange, is you can have a much more quality interaction between you and a drug user after they've shot their dope. It's kind of like, whew, that's done. Now they got a minute, right? Sometimes, honestly, you just think it is a minute because they're out scoring and getting, you know what I mean, this kind of cycle. But at least there's this pause. That's when they can go to the chill lounge or notice that there's, you know what I mean, that's when people are open to talking, because that's the social thing. The problem when the needle exchange is, because our needle exchange kept doing this too, they kept restricting the numbers of needles, and you could only get 7 at once, and it caused a terrible outbreak of disease. It did not cause people to come in and talk to the needle exchange, but their thinking was, if they have to keep coming here to get needles, we can talk to them about going for drug treatment, and then we'll get really high rates of people going for drug treatment and getting off drugs altogether. The problem with the strategy was they didn't look at it closely enough. So when people want needles, I just go shovel them off the back of a truck. I could care less. You walk into VANDU, you'll say, I need some needles. You go over there and help yourself. That's how uninterested we are. Although we had to, the energy changed over a period of time because the agencies used to have to buy their needles, so they felt kind of protective of their supplies, or they couldn't get new ones. And the last thing you want to be is an agency that's run out of needles. So you have to sort of ration in a logical way. But as soon as we broke through on this, and they said, they got so worried because the drug users in the downtown east side had a 38% of prevalence. Now, I don't know if you guys know what prevalence is. Prevalence is how many people have it. Seroconversion is how many people caught it this year. So your seroconversion is the rate at which people are getting it, but the other, because they don't die once they get it, they sit around. But once you've got a ton of people with AIDS, The rest of the people have a hell of a time not catching it from them. So if they don't use a condom, you know, every time, you know what I mean? Or, you know, or that you mix up the needles. Like if your kid was a injection drug user and you were completely out of control and you had no influence over anything except which town they were going to go shoot their dope in, choose a town that has a really low rate of HIV or a bunch of places where they can ensure that they're not going to end up getting it, because that's how people get it. It's just in the hazards of the daily life of a drug user, mostly the criminalization. So in terms of the strategies with the needles, there's never a strategy to pull them back. What we do know in Vancouver is you can give out tons of them and not get anywhere because the people still hate themselves and because, you know, they weren't going out at night. We started a nighttime needle exchange, and the shock, right when the Vancouver Injection Drug User Study had interviewed all these drug users, and they said, here's the other trap that you fall into. I'm boring all you guys if you're experts on this. If you tell drug users don't share needles, and then you go up to them after and you say, are you sharing needles? They'll say no. Then you say, well, are you borrowing needles from other people, or do you ever lend syringes to other people? They go, oh yeah. Well, of course that's sharing, but they don't, you know what I mean? It's like, oh my God. So they have to ask the right question. So they say, are you borrowing and lending? They found that people were borrowing, lending syringes at night. They said, why are you doing that at night? They said, because we can't get needles at night. We open a nighttime needle exchange. So when we're in trouble for opening the nighttime needle exchange, we have the data that this is exactly when drug users can't get their things. So the cops are mad at us, the city's mad at us, and there's like, you know, 3 or 4 VANDU members who are active addicts usually, sitting at a table from 6 o'clock at night to 6 o'clock in the morning, giving out needles. And there wasn't much they could do about it. Finally, they built an indoor needle thing because the police just said, you have to get those people out of here. That's the other trick. Anyone who starts an outdoor needle exchange and runs it as a fixed site, it puts a lot of pressure on the system. If they're saying they don't have any money, they'll get money. It'll just show up somewhere, and they'll, you know. So that's been a good, I don't even know if I answered your question. Oh my God, good. Any other questions? Yes?
I'm an employee at Carmichael Outreach.
Right?
And so my position is I'm housing coordinator through the HIV Strategy for Regina. And so this is a new position that's opened up. And it's great in theory, but in a city that has a 0.6% vacancy rate and a government that is seemingly unwilling to contribute dollars to social housing, I'm just not sure what to do. And you know, I've looked at some of the housing options that are being offered in Vancouver, and there's these low barrier places that, you know, you look at the application form, it's like, what shelter are you coming from?
Right.
You know, where is your contact? Not, can you name 3 of your most recent landlords, and what's your credit check? And we don't have any of that. What do you do? How do you get that kind of stuff started? Because it seems to me that housing is such an important component of people's...
It is. It's a huge predictor of these kind of outbreaks, and it's no accident that you guys have seen this escalation during this time when the housing just clamped down to nothing. It's the risk factor. It sounds like they gave you a job to feed a baby with no mouth or something. It's the strange. That's like torture. It's very strange. It's who's funding you? You can't go back to your funder and.
It's the health region.
Oh, it is the health region. So you know who opened the first? Actually, this is historical. The very first housing ever built in Canada was built by the health department in Toronto. And it was because the middle class got frightened that their kids were going to catch cholera or something. You know what I mean? So anyway, they did a good thing, even though, well, it's still a good thing no matter what they did it for. But the health department in Vancouver, you start to try and create a fight between health and housing. And of course, housing does it. We don't have any money. You don't have any money. They do this thing. And then I don't know how we did that. We just kept up the fight. And you keep the data going. Have you guys got data to show that it's a predictor for HIV and that you can't stop an HIV epidemic when there's no housing? Because this is true. It's true as far as I know. I can send you anything I've got on that.
That would be great, actually.
Okay. And then that would be like the talking point for activism. So whether, like, we've gotten involved in the Woodward squat, the VANDU. We had 3 VANDU board members in there on the first night. God only knows who figured out there was no dog on duty and how to get in. But we had been looking at that place for a long, long time. So, but we had an organized meeting, a group, which is the beauty of the group. The group is sort of your soldiers on the ground, you know. Call VANDU, we'll be there. So the thing about the housing was that the first places that were bought, that were that low threshold housing, were bought by the Vancouver Coastal Health Authority. And they made a sort of political to-do about it because they do get vast quantities of money. I don't know if anyone's ever seen the healthcare budgets. They're huge. And so it's almost no sweat off their balls to buy some bloody housing anyway because they have so much money. And the housing prevents these hugely costly diseases and stuff that's going to way down, not even down the road, almost immediately start costing them tremendous amounts of money. I've concluded, though, that the governments actually don't want to save money at all. That's why they like prisons, and that's why they like making everyone sick. They really, really want doctors to get rich and hospital people, and maybe they're going to privatize the healthcare system, and they privatize these prisons so their friends are going to make billions off of it. And that seems to be the current thing in place. But it doesn't mean that Saskatchewan people and citizens of Canada are going to go along with this. And that's where we need to seed our activism at that point. Because even if, I'm not sure who else I've ever heard of building housing, whether unions have ever done it, but it's a kind of, there's this little embarrassment factor that they used then. The health department came to the thing and they said, they had a meeting, they said, you can't come in unless you have $1 million. Because you know how you'll go to do something in the community, everyone and their dog wants to be at the table. But I, of course, wasn't there. I didn't have $1 million. But I heard they said that. And it was David Levy who did it. He is a Van City financier guy whose father was an NDP cabinet minister. So anyway, that was the catch. I know how to do the activism end of that, which is although I've never done it at 40 below, but we've done a number of initiatives where you start to, because the alliances here, other than the homeless strategy people, the HIV strategy people really need to, you really create your critical mass of the activists in each of their fields so that they all really understand that they are completely overlapping these issues, and then figure out what you can work with. But I don't know if that's very good. Have you been to the health department? Have you actually attended do they have meetings here? We have a health authority. We used to have monthly health board meetings, then they turned the board into the authority and it went all right wing. Everyone on there used to own a forestry company that shut down or something. And they're all like, I just have nothing to do with health anyway, but they all sit there. But we would go, it was a tremendous point of activism, and we would bring people that were HIV positive who had nowhere to live. They're public meetings. They only have 4 a year now. They regret them, I'll tell you, when we show up. But the media is usually there. But anyway, start finding out what's on. I mean, the other thing, until I started attending them, I'm a bit conceited, mostly because I live on welfare now, so I have nothing else to rest on but my laurels. The police board meetings never used to, no one used to go to those, and I found out where they were and started showing up. And they actually have police boards. Who knew? I didn't know, and so we started going. None of the drug users would come with me because they wouldn't go in the police. You were just, oh, cops, are you nuts? So, we slowly built that one up. But it was about showing up everywhere we could and creating a little, and I don't know, now you've got what you call clients, right? You got a waiting list of people who are trying to get housing. You could kind of turn them into a lobby group. And don't know how much budget you have to do that, but we would do it with the $3 to attend the meeting, be really strict, you can't leave early, and I don't care if you have made an appointment with your doctor, too fucking bad. You know what I mean? You just kind of jolly, just get the thing going, and then leadership will rise out of those ranks, and you'll start to find out what people's strengths are, and then find out what's out there, like who's in charge of housing, and meeting with ministers has always never worked very well for me, but going to city council, going to the legislature, going to the board meetings. Those are the ones that have caused us the most kind of ruckus. And you might have to have a stand-in for you if your job's threatened by doing that. Like, oh, there's nothing I could do. It's the whole wait list that whatever, I don't know. I don't know how much you can get away with. It's, at some point, a job feeding a mouthless baby must be mental making at some point anyway. You wonder. You have my deepest sympathy. It's weird, eh? She's supposed to found housing for people,
Yeah.
and there is none?
No.
Oh my God. Oh my God, well. So that's the only last warning I want to say is if nothing does get done, what we know about epidemics, and Bud Osborne had the privilege of being on the Vancouver-Richmond Health Board when the epidemic was first announced. And he said that in that room, scientists and board members actually discussed doing nothing. And so it's kind of like if you have a petri dish, and I don't know how many of you are biologists, but if you just don't do anything and you don't keep feeding it, eventually it'll all die off. You could contain an epidemic with this philosophy that eventually everyone who's vulnerable will catch it, and then no more people will catch it. It's a really, really bad idea. But, and then he went mental on them. But the idea that people don't think this way, you know what I mean, anyway, because that's, once you get a population that's got a certain level of HIV, it's extremely difficult to bring it down. Very difficult. Because you can't have any mistakes, and you have to then create a really seamless service thing. So that's the warning about the urgency. It is urgent for sure. So anyway.
Well, I'd like to thank Anne. She's had a tireless schedule. She got in here yesterday, Carmichael all night, radio interviews today. So I'd just like to thank her for coming here and helping us with the HIV health crisis that we have in our province here. I'd just like to thank Anne.
Thank you.